Be good to go.
Thank you. Good morning. Welcome. Welcome to those of you who are on Zoom. It's terrific to gather for grand rounds. I'll start with a few announcements, and then it's my privilege to introduce Dr. Liz Goldberg. So just in terms of announcements, next grand rounds is November 2nd. Jenny Ports will be our speaker. Next Journal Club is November 9th. That again will be by Zoom. And we will have evaluations after this grand rounds. We hope to have paper evaluations, and also we will put the link into chat. So we really would appreciate you filling out the evaluation. We're able to give feedback to the speakers, as well as take your input for next grand rounds topics. However, it's not that great when we have, say, 7 of 39 people who fill out the evaluation. So please, we hope to have, I think we had 9 last time, so let's get into double digits for evaluations. So in terms of introduction, Dr. Liz Goldberg, this is her 1-year anniversary this week of being here on campus, so we're really glad that she moved to join us. She is a practicing emergency physician and associate professor of emergency medicine. She's an alumni of the Brown University Postdoctoral Research Fellowship in the Center of Gerontology and Healthcare Research, and has a master's in epidemiology. During her fellowship, she received an RO3 from the NIA to facilitate her transition to aging research. For this proposal, she designed and pilot tested a fall prevention intervention for older emergency department patients, and it's now considered a national model for ED fall evaluation and treatment. So GAPcare was found to be feasible, acceptable to patients, caregivers, and clinicians, and reduced recurrent emergency department visits for falls by 66%, which is really tremendous. She subsequently is funded by Paul B. Beeson Career Development Award to continue her work with a larger GAPcare trial, and is also using the Apple Watch in this trial for fall outcome assessment. She's received funding from several other sources, including Blue Cross Blue Shield for Equipped, as well as was chosen to be a plenary presenter at the 2022 American Geriatric Society Conference. She's also co-founder of My COVID Risk app, which is a publicly available tool used over 1 million times by individuals looking to better understand their risk of infection. So we're very excited that Dr. Goldberg is here to give us updates on her current research.
Thank you so much, Dr. Lum. It's really wonderful to be here with all of you, and I'm very humbled to be able to speak about falls to a group of geriatricians. This is the first time I'm doing geriatrics grand round, so I get the irony of an emergency physician standing in front of a group of people with a focus on fall, and I really welcome any of your questions throughout. I'm thrilled to be here. As Dr. Lum mentioned, I do have funding through the NIA, and I'm going to be presenting some of that work today. And I also want to mention that Apple Watch devices for my research study were supported by an Apple Investigator Support Grant. I'm happy to talk to other people who want to use devices in their research more about that later. And I want to acknowledge all the people that have helped contribute to this work. It's a true team effort. So today I'm going to talk a little bit about our GEMSTAR and Beeson funded trial of GAPcare. We currently are recruiting patients in the University of Colorado Hospital ED for this trial. So I'd love your input on that. I'm going to share some of our early results. We're also going to talk a little bit about lessons learned for preventing future falls in the emergency department, because I think there is a really important role for geriatricians in this work, and geriatricians and PTs and pharmacists have informed my work throughout. And then we're going to talk about gaps in falls research and maybe where we need some more collaboration from folks outside the emergency department. Specifically, I'm going to be talking about GEAR, which is an NIH-funded initiative to kind of answer broad questions in emergency related to geriatrics. And I think is a wonderful resource for those of you that are interested in acute care medicine and how we can move the needle for geriatric-related syndromes. So I know why you care about falls, but why do emergency physicians care about falls? So this is data from the CDC that you can see here. It shows the leading reasons for injury among US citizens. And you can see that falls is the leading reason. We also see a lot of drug poisoning and firearms and motor vehicle accidents in the emergency department, but falls are really our bread and butter. And to be honest with you, the status quo is kind of sad in the emergency department for what we do with falls. So the vast majority of patients, about 97%, get a trauma evaluation alone. And we rarely look into causes for why people fall, which makes it really hard to prevent future falls. We also know, based on some large research that Hoffman et al. Did using Medicare claims, that only about 1 in 4 older adults actually tell their primary care doctor about falls. So we know the emergency department could be a really valuable, teachable moment to talk to people about why they're falling and prevent future falls, but the status quo is we're not doing that. So 2.8 million older adults visit EDs annually, and folks that come to us for a fall actually have a 30% higher risk of falling again within the next 6 months compared to age-matched control. So not only is it an important setting because we have caregivers, we have older adults there already, it's also important that we make a difference then, because a lot of times it takes people a while to get into their primary care physicians if they even have one. And falls may be preventable in the ED setting, but prevention efforts aren't widespread. So this is what's going through an emergency department doctor's head or clinician's head when we see a patient with falls. You can see, we're thinking about x-rays and CT scans. How do we work this up? How do we make sure we don't miss any injuries? As you know, many older adults come to us and may not be able to give a good history. They may be coming from nursing homes. We think about all the consultants we need to get involved. Each different hospital has a different trauma activation criteria. So you need to ingrain that in your head. Does this person need a tax consult today? How do I get their caregiver involved in the nursing home? Even call the caregiver. Let me look through the 100 pages that we got from the nursing home about this patient because I know nothing about them. And could this have been syncope? Does the patient actually warrant admission for syncope? So that's a common question that we try to answer. Are there an anticoagulation? How do we appropriately control the pain of a patient that's on 20 medications and we might actually not have their accurate medication list? So these are just some of the things that we try to consider when people come in. So what I realized is that if we're going to initiate falls prevention in the emergency department, we need to make it seamless with our workflow, and it's probably not going to work if we add to the list of things that emergency department clinicians and nurses have to do. So we need kind of an external team to come together to approach this. So back in 2017, when I was a postdoc, I went to our case managers in the emergency department and I said, what do you need for older adults? I really am excited about this grant mechanism. This is like my way to become a physician scientist. So tell me what you think we need. And they said, we need more PT presence in the ED. There's so much functional impairment. There's so many people that go home and then return right back. And we don't really have a mechanism for how to get older adults seen by physical therapists and get that evaluation. Right now, all we're doing is this trial of ambulation. And if they can walk, we're like, okay, it seems like you're safe to go home. But that's really, I think there's better methods. So I went to one of our geriatric PTs, and we didn't have PT or pharmacists in the emergency department at the time. I was working at a level 1 trauma center in Rhode Island, the only tertiary care center in Rhode Island. And they were so excited about getting involved in the emergency department. So I was like, this is great. I'm going to design an intervention. And with this $75,000 per year for 2 years, I'm going to do a randomized control trial. And my mentors thought I was crazy. But I proposed it and they funded it. And so what we decided to do is for patients coming into the emergency department that are 65 and older, that are not coming from a nursing home, but are likely to return back into the community setting, we wanted to see if we could do a really brief intervention, bringing together pharmacists and physical therapists to see the patients while they were in the ED and address very briefly in a 20-minute consult what their modifiable risk factors were for falls. So what did this look like? Our control group, we actually approached and we read them a brochure from the CDC about home safety. So it was a checklist about what they could do at home to make their home environment safer. And then in the intervention group, as soon as that patient was seen by the emergency physician, our research staff went into the room and introduced the study, got written consent, and then a pharmacist would meet with them and just address 3 recommendations for how to reduce fall risk. And that was based on some research that was coming out at the time about brief motivational interviewing. So the pharmacist just asked them, what do you know about these 3 medications? Looks like you're taking Benadryl to sleep at night. How is it working for you? How do you feel in the morning when you wake up? And together with the patient and the caregiver, if they were in the room, they just came up with 3 recommendations. I'm going to share what that looks like in a moment. The nice thing about having the pharmacist go in first is often patients are collared when they initially come into the ED, and it takes a while to get them to CAT scan. So a lot of our patients were laying flat while the pharmacist talked to them, and we knew the PTs could not do that, but the pharmacist could. And then a physical therapist went into the room, and they actually did some standardized fall risks assessment, including the Tinetti fall score and the AMPAC 6 clicks. We initiated the 5-time sit to stand, which it turned out no ED patients could do after a fall. But we chose those 3 working together with our geriatric PTs. And then we had a short checklist that was instrumentalized through a dot phrase where they could talk about footwear, they could talk about assistive device use, they could talk about if rehab was the right choice, or if they could just, if the person was more functional, they could suggest outpatient PT. We had a mechanism to suggest home PT if they were homebound. And then in patients that were like 65 and were just there for a lac repair, and this was their first ever fall, and they seemed very functional, we just gave them community resources to like Otago and other evidence-based programs. And then our plan was at 6 months, we would do a home visit. And we would ask them, did you actually put these pharmacy recommendations in place? Show us your current med list. And we also asked them about every single PT recommendation if they put that into practice. We also called them at 1 month and 3 months to see how they were doing. Our outcome initially was falls. We wanted to see how many falls patients had in both arms, but then we realized that patients don't really return fall calendars very well, and a much more objective outcome would be fall-related emergency department visits, all-cause ED visits, and fall-related and all-cause hospitalization. So that is the outcome that we decided to measure at the end based on the completeness of data. So what did this look like? I approached the EPIC team. You can see this was back in 2017. And I said, we really don't want the ED physician to have to call the PCP we don't want to snail mail consult notes. So how do we get these notes to the PCP? So we instrumentalized it that as soon as the patient's AVS was sent to the PCP, the pharmacy and PT note were appended, because we didn't want the ED doctor to make medication changes in that older adult because they don't necessarily know all the medications they're on. And we also wanted to make sure that the PCP was in the loop, but calling the PCP has proven to be difficult a lot of times in emergency departments. So we wanted to make sure this actually happened. So we instrumentalized this in EPIC so that nothing had to be done from the ED team. And you can see here's our pharmacy note. It's very basic, just name of the medication, strength, nature of problem, and recommendation. And then here's our PT note. We have our fall risk assessments on the top there, and then recommendations. So the idea was in and out in 20 minutes, checkbox style. And the PTs actually really struggled with this because they're like, we like to do a really comprehensive evaluation. We want to spend an hour with the patient. I said, listen, they have to go to CT, they have to go to X-ray, they have to see a pharmacist. This has to be brief or it's not going to be feasible in the ED. And so reluctantly, they agreed. So what did we find? We assessed 478 people for eligibility. Any patient that was, when we first approached the ED clinician, we said, do you think you're going to discharge this patient? Because if you're going to be admitting them, then they can see PT later. So if they were going to admit them, we didn't include them. If they were at skilled nursing, we didn't include them. And then a fair amount of people were altered or intoxicated. But those that were not ineligible, we randomized. And then you can see about 88 declined evaluation. So we heard a lot like, I don't think I actually had a fall. This was just a trip. I just slid down off my chair. This is not significant. So, we had to coach the research assistants to kind of get over that fall is the stigma issue. And then surprisingly, sometimes when family members were present, people were like, I don't really want to be involved with research right now. I want to catch up with my daughter. So we did allocate 110, 55 to intervention and 55 to usual care. And you can see here, not everyone got the pharmacy and PT evaluation. So sometimes what happened is the patient ended up having a head bleed, surprisingly, and then PT would not mobilize them, or we found a lower extremity fracture that made it really difficult for PT to work with that patient. And sometimes the patients just decided, as soon as discharge was ready, they wanted to get out of the emergency department, and PT was the last step after imaging was resulted. So that's why PT, there's some missingness there. Our median age was 82. This is predominantly a study of white females. We're actually seeing more diversity now that we've moved the study to Colorado. About 20%, 15 to 20% were cognitively impaired by the 6-item screener, which is a really fast test of screening for cognitive impairment. They had functional impairment, about a third lived alone. And then we did include people in assisted living, and about 20% were from assisted living. We were very evenly matched in intervention control, which shows our randomization worked. And here's some of our outcomes. We actually found that we didn't prolong ED length of stay in our GAPcare intervention arm, which I was happy to see, because if you're going to do an intervention in the emergency department, it has to be fast. And if you're slowing up ED workflow, the medical directors are not going to embrace that. So I was happy to see that. I think that's because it takes a really long time to motivate staff or to do yourself to ambulate the patient. And that was often the last step in these falls evaluations for patients that came to the ED. So the fact that, PT would come, our research assistant would come and would do that. So even in the control arm, our research assistants did a tug screen, like a timed up and go. And so I think that potentially sped things up. And also that we came up with a plan for the patient for what would happen after they left. So they would go to home PT or outpatient PT. So ED docs like that, they could kind of allow that team to make that plan. About 10 in each arm were hospitalized. So we analyzed our results by intention to treat. So if after they were consented, they ended up being hospitalized, they were still analyzed in the group for which they were initially allocated. And then you can see slightly more in the GAPcare intervention arm were discharged to SNF. I think that's because when our PT saw the patients, they were like, this person is not going to do well at home. And it was kind of like an early warning sign that they picked up on that we in the ED would not have picked up on. What about satisfaction with care? So we asked patients, 99 replied, we asked caregivers, and we asked ED clinicians what they thought about this and whether they would recommend it. And you can see there was high satisfaction. Usual care is in the bracket, so actually people were satisfied both ways. So these are our results. You can see in blue, it's control patients. And we did our analysis, we did a negative binomial regression analysis, which keeps in mind kind of the person months that every person contributes, because as you know, with older adults, there's a lot of censoring in the data due to moves to hospice or death. And so we found that this regression model fit the best and is generally recommended for falls research. So we saw in the 6-month follow-up in our control group, there were 66 all-cause ED visits in the control and just 30 in the intervention group. For fall-related ED visits, we saw 24 in the control and 9 in the intervention group, and those 2 were significant. And then for all hospitalizations and fall-related hospitalizations, those weren't significant, but you can see there's a difference. So we reduced fall-related emergency department visits by 66%. That's what this comes out to. And you can see here, this is a mean cumulative function curve. So it shows over time how many fall-related ED visits occurred in both arms. And blue here is the usual care group. So you can see it really bears out in the data that there's a lot of ED visits that happen potentially before patients are seen by their PCP. I just thought this was a really great visual way to kind of depict what we were seeing in our follow-up. Also status by the end of the study, about 10% of our patients died within 6 months. So they were fit enough to go home after an ED visits, and then 6 months later they died. So I thought that was interesting, probably not super surprising to this group, but it was surprising to this ED doctor. And then we saw some withdrawals and some loss to follow-up in the study. So this is what some of what our pharmacy recommendations look like. So up here you can see that we talked a lot about ibuprofen in the study and how it can increase risk of digestive system bleeding. Lexapro, so a lot of antidepressants were dosed higher than would be recommended in geriatric patients. So a lot of the recommendations we made is maybe you want to modify this dose and see if you have similar improvement in your symptoms with lower doses. And this is a patient with dementia. So we talked with the pharmacist a lot about like how can you recommend sleep hygiene without being on sleep medications, and the pharmacist here writes, we recognize this is very hard in dementia, but maybe it's worth a discussion because mirtazapine does increase fall risk. We actually saw a lot of patients in the ED that that the PTs recognize they might have Parkinson's, and we didn't exclude people with Parkinson's from the study. So we did talk a lot about Sinemet dosing. And so you can see these are very brief notes. They're written so the patient can somewhat understand it, but it mainly targeted towards the primary care doctor. And one of the nice things that I saw doing follow-up anecdotally is because this note was in EPIC, if there was a specialist that was prescribing like a cardiac medication, they could see this. And sometimes the specialist actually noted in their note, like, it looks like this is causing orthostatic hypotension. Now the patient's falling, let's try this instead. So there was some modification also from specialist prescribed medications. So 73% of our medication recommendations were adhered to partially or fully. There was more uptake of using over-the-counter alternatives like Tylenol instead of some prescription medications for pain, using increased precautions when taking medication with a known side effect. So that's a lot of times the blood pressure medication getting up slowly. We didn't recommend very often to stop medications completely, but sometimes we recommended that and change timing or use over-the-counter pain relief. And then this is what our PT notes look like. You can see here the 5-time sit-to-stand was not applicable because our patients weren't able to do that. We had very few patients that were able to complete that. And what the PTs often did is they left a note at the bottom of the chart about gait training and balance re-education. This patient was someone that they thought might have Parkinson's disease. So you can get a sense of what was in here. So 68% of the PT recommendations were adopted either fully or partially. And I'll say here that this is a subjective assessment. So we did surveys at 6 months and we asked them if they did it. We also asked them at 1 and 3 months if they made those changes. And this is what patients reported. So it's possible that the uptake was actually lower. In our future studies, we're planning on measuring this through Medicare data. We also did some qualitative studies, so we wanted to understand how the uptake was, and I'll just share 2 quotes that I thought were illustrative. So this patient is a patient in their 70s, and she actually came to the ED twice, and the second time around, we got her to enroll in the trial. And this is what she said. So the PTs had suggested to her both times that she go to a sniff. Why don't you go and live in one of them? I says, no, I don't like them. I don't, it's too clustered. It's all right for people in their 80s and 90s, but not for me. I felt like I was an old lady. I came home, they checked me all out. I was okay. So that's her first ED visit. And then I came home, I had one more fall. They took me to the ED to check me out and they said that I should put me in for rehab. So I said, okay, that was fine. So sometimes it's a process and we do get to see these patients multiple times. And here's another kind of sad anecdote from a caregiver. And this talks about fear of falling a little. So only hurdle now is to get her out of the house to see her primary care physician. He has put his foot down and said he's not renewing any more of her prescriptions until he sees her. She doesn't want to go out of the house, but she's afraid to fall. So we heard that a lot in our qualitative research when we saw patients, like people said that they would go to museums and they would hug the walls like this after their falls because they were so afraid. And I welcome any suggestions on how we can address fear of falling in the study, because we're measuring it, but we're not really doing much for it. So what did we learn in this 2-year pilot trial? So there was a lot of negotiation, and we did end up adjusting our recruitment times to availability of pharmacy and PTs. And I think this is a sustainability issue. Like, how are we going to staff emergency departments? So we have PTs and pharmacists around the clock. That's really tough to do. So we really only recruited during 7 to 4 Monday through Friday, which I think, is a limitation of this work. And soon we'll be trying a telehealth version of PT and pharmacy to see if we can offer more around the clock care. We had to develop new communication strategies with the IT team to save time and reduce workload. We knew like snail mail to get in touch with PCPs or calls wasn't going to work. We ended up doing quarterly meetings with our research staff and pharmacists and PTs. So we would present data. The one major thing that PT said when I first met with them is, we're often involved with research studies. We often say yes, but no one actually comes back to us and shows us the data, or if there's an improvement, we rarely ever get to see kind of the fruit of our labor. So we made a commitment to do quarterly meetings, and we actually just had our first meeting here with our PT and pharmacy staff to show them initial data. And then when we had the PT, so the PT directors were involved at Rhode Island Hospital. When we had them first walk through the emergency department, I got our medical director in the emergency department to walk through with us too, so that they could discuss, how this would work, because they wanted stairs in the emergency department. So we ordered some stairs. They wanted like a supply cabinet. So there were a lot of like actually operational issues to address when you start to have PT in the ED. So I thought that was helpful. Some of the things that we wanted to do that we couldn't do is, for instance, like orthostatic vital signs and visual acuity screening. We just didn't feel like we had the time. That was a critique in the NIH review, but we couldn't address that. And then we, considered having the nurse do some of the functional measures, but realized that it probably wasn't very pragmatic as they were really busy already. And then we did the automated messages, not one-on-one calls. So I actually talked to Mary Tinetti early on and Dr. Tinetti in creating this intervention. She's like, you really have to call the PCPs and geriatricians. And I was like, I don't think we can do it. So then I was very lucky to get funded with a BESIN award, which is what we're doing right now. And for the BESIN, we decided to integrate wearables into the GAPcare study, and also to recruit more people into GAPcare. So our first year was really kind of field testing how these wearables would work. We weren't sure we could put Apple Watches on older adults, train them how to use them in the ED, and get them to wear the Apple Watches and charge them every day, especially with a median age of 82 and some people never using a touch screen. So the first year was really about trying that out, but we had a contingency plan in the award the whole time that said that, if we can't do this continuously and can't get them to wear a watch for a year, then we're just going to do periodic measurements and show up at their house and like put the Apple Watch on and do our measures then. And one of the motivations for this is that what we found when we analyzed our data in GAPcare 1 is that the PTs did such a beautiful job with their functional assessments in the intervention arm, but then we looked at the control arm and we didn't have the same measures in that arm. And so it really limited the analyses we could do. So we thought, okay, well, Apple's come out with these not only like fall detection algorithms, but they've also come out with Research Kit, which is this tool that I'm going to show you in a minute, whereby you can do these mobile at-home functional assessments and cognitive assessments. And I was like, well, that'd be great if we can integrate this. We can get more standardized measures. So as a research tool, it would be really useful. So then after the field testing phase, we aim to do the clinical trial, and you can see we're at the end of the clinical trial now. I'm not going to kind of discuss this verbally. So we, in order to actually get these measures into REDCap, we had to create a research app, which was an interesting process. And you can see here, the patients were actually alerted when they had to do certain research tasks. And the patients could also choose what kind of sensor output to contribute. In order to create a research app, this is what we did. We initially programmed surveys in REDCap, and then we selected what kind of measures from Apple's Research Kit we wanted. And there's health kit measures, which are physiological measures such as heart rate and heart rate variability and fall occurrences. And then there's also active tests, which are actually cognitive and functional assessments. I had to get our institution to enable API. So API is a way for research apps to talk to REDCap. So if you want to automate that data transfer directly into REDCap, then you really need to use API. A lot of research studies, what they do is they give these devices to patients and then they wait until the end of the study, like a year later, and then they download everything from the device. But I knew based on GAPcare 1 that about 10% died, and then we had all these withdrawals. So I knew we would miss that data. So it was really important to me that we got that data in real time. And that way we could also track falls as they were occurring. And then we pilot tested it to make sure that the technology actually worked in different areas in the hospital and that we were actually getting all that data into REDCap. And then we started our 30-day field test where we asked people to wear it for 30 days. And that started in mid-February of 2020. We'll get to that in a minute. So we gave, our plan was to recruit 30 patients and then do an interview after 30 days. Same inclusion exclusion criteria as before. I ended up speaking with a neuropsychologist and talked to them about the cognitive test that Apple had available. And what we ended up choosing was the trail making test, the Stroop, because those are commonly used neuropsychological tests, and then reaction time because we felt that that was a good test to kind of predict falls because people with slower reaction time would presumably not be able to brace their falls so much. And then for mobility, we did a gait and balance and a timed walk test. So this is what this looks like. So these are these active tasks that come inbuilt into Apple's research kit that you don't have to do any programming for, you just select them. So Apple has sensors within both the watch and the phone. And you actually don't need a watch, you can just use a phone for these measures. And it works that if you're wearing either a bag around your, a bag that's kind of around the waist, or if you put the phone into a fanny pack around your waist or into a back pocket, you can just have the person do these gait and balance tests. And not only does it write out exactly what you need to do on each screen, but it actually reads it out loud to you, and there's sensory stimulus. So you get a vibration every time you're supposed to do a new thing, which I thought was really great to have this kind of multi-sensory kind of experience as you do this. And so our research assistants right now are doing this on all our trial participants. You know, one of the challenges, of course, with these gait and balance tests and timed walk tests is we're doing it in the emergency department. So, you know, there's construction going on, there's like stretchers coming by. And so I would say it's not perfect, but it's been an interesting process. So if you're planning on using these tasks for your research, definitely I'm happy to talk to you, but there's a huge variety of different tasks that people can do. And then it tells you sort of what sensors being used, like accelerometer is kind of speed in this direction, gyroscope is rotation. And so when you get the data back, and we're analyzing that right now, you can see exactly when the patient walked and then they listed to their right, you can see exactly how that happened in the XYZ axis. It's really really kind of been fascinating to do that analysis. And then at the end, which is where we are now, we're using all this data and creating a combined data set. So we have a separate REDCap for our Apple Watch measures, we have a separate REDCap for our clinical trial survey measures and the things that the research assistants do in the emergency department, and all of that comes together into combined data set. And then our outcomes were these intervention process measures, such as how long did it take in the emergency department to do the intervention, this intervention initial efficacy. And then we had hoped to do this Apple Watch measure validation, because even though Apple Watch puts out these white papers, they're not externally validated, these measures yet. So we had hoped to use the NIH toolbox and the Apple Watch measures at the same time. But it was taking a really long time in addition to everything we were doing already in the emergency department. So we have tabled that. I'm not presenting trial results today, but we have some interim kind of results. One of the things we noticed is that Apple actually doesn't put out any manuals for their Apple Watch. And when we were sending patients home with Apple Watch, they were calling us. Apple's very clear, we don't do tech support for research trials. You have to do that on your own. So we trained the research assistants. I had some really young and savvy people to do it. But we realized we needed to create a manual. And fortunately, one of my research assistants who just graduated is a neurologist now, Daniel Strauss. He created this really awesome training manual that just went over like everything that you might want to know about the study, and also kind of some of the cool features in Apple Watch to get people to continue to wear it. It was a lot of work. Another one of my students, Hari, who's actually a computer science undergraduate, now a first-year medical student, wrote this paper about how do you actually go from, choosing to use these measures into getting that data. And so the whole tech stack we've written up now, and you can reference this paper if you're ever interested. And I have a little more time. Just 4 slides about how we're doing right now in our trial. So when I was recruited here, we were halfway through recruitment in our clinical trial. We want 200 patients. We were at about 80 patients in Rhode Island, and we were recruiting at 2 places in Rhode Island. And I was told, if you move here, PT and pharmacy will work with you, and we will, launch the clinical trial in Colorado. And I was like, I need confirmation of that. So I actually talked to EDPTs and pharmacists before I moved here, because it was important to me to finish my KOR trial. And fortunately, they were like very excited about it. We have 24/7 pharmacy here, but they don't do any consultations at the bedside right now unless you're a stroke or critically ill patient. So that was kind of a new ask of them, but they were agreeable. And then PT, we have about 12 hours out of the day, and they were just thrilled to be involved, and they felt they had time for this. And actually the way they do billing here, it's already part of the ED bill to get like pharmacy and PT services. So I didn't have to, carve out additional money in the grant to do that. Actually, you see health set in the end. So I thought that was a great facilitator too. So when we closed the study last January in Rhode Island, we had recruited 118 people there, and now we've recruited 48 patients here in Colorado, starting, took about 3 months to start it up, and we started in March of this year. So we've recruited 48 since then. This is our initial data on 46 patients. We're seeing very similar reasons why people don't want to be involved. And overall, we've enrolled 22 into the intervention arm and 24 into the control arm. You can see very similar here. There's 6 in each arm that were discharged to SNF, about the same were admitted to the hospital. Most go home. It's taking longer for our pharmacists and physical therapists to see patients here. And part of this is only 1/4 of our patients are recruited in the main ED. 3/4 are recruited in observation, which is kind of nice for our pharmacists and physical therapists because they know they have more time to see patients. The other thing we're running into here is because pharmacy and PT is already present in the ED here, some of our control arm is inadvertently getting PT because the ED docs here have kind of, grasped onto this idea. And actually, when I came to Colorado, I found out all of North Colorado was doing GAPcare already. They had read my study and they had implemented GAPcare, and it's already happening there. So that was kind of a nice surprise. And this is just to give you a slight sense of how efficient we are in this ED. This was a shock to me because it takes about 4.5 hours for us to get a falls patient through the emergency department in Rhode Island. Here, it's sometimes just 90 minutes. So this is based on very few patients, but you can see how hugely efficient we are in the main ED. So that's a good thing to think about if you're thinking geriatric consult in the ED, because we move people through very quickly. And part of it is we're actually remunerated for our efficiency here, which is not the case in our old emergency department. But also, I feel like I'm the rate limiting step all the time. Everybody else just has very good systems in place to do what the patient wants, which is to get out of the hospital as quickly as possible. And I just want to briefly talk about GEAR. So if you are looking to understand what is the body of research on geriatric syndromes in the emergency department, there was this very, very large effort by the Geriatric Emergency Applied Research Network in the last 5 years to look at all of the geriatric syndromes and create systematic reviews, really scoping reviews of where we are now. This was initially funded by an R21, R33, and you can see we initially focused on delirium, care transitions, medication safety, falls, and elder abuse. And this is not only emergency physicians, this is geriatricians, PTs, pharmacists. And now currently we're focused only on dementia and their caregivers. And there's an R61, R33 funded. I'm not the PI of this study, but I've been involved in a lot of these core groups. And so it's very nice to be able to go to these scoping reviews and see what has been done. I'll just show you what we did for falls. We looked at 2 specific questions, which were kind of distilled by this group, which is in older adults age 16 over who present to the ED with a fall, what is the effect of fall prevention interventions in the ED and peri-ED period? And we found 3,181 abstracts and initially then included 32 studies. And then we also looked at the effect of fall risk stratification, a fall care plan. And I think in our falls group, William Hung was the geriatrician in that group out of New York. So what we found were interventions were often bundled, very often just like GAPcare, which made it difficult to understand how effective each intervention component was. The outcomes varied. There was really no direct comparison of fall risk assessment tools, and there were really limited studies on peri-emergency care, like the role of paramedics and EMS. So these are the top 5 research priorities now moving forward in emergency care for falls. Really looking at EMS role in peri-ED care. Can paramedics do that assessment, of fall risk assessment, when they initially arrive at a patient's home, even before they come to the emergency department? What is the best falls assessment tool? What about some patient prioritized outcomes, such as maintaining independence or reducing fear of falling or stigma? That's not often measured. What is really the optimal outcome? Should we try fall related ED visits or something else? And then what kind of intervention components are most effective? We also have this really great supplement. I could tell you it took a very long time. We looked at all the possible fall risk assessment tools that could be used in the ED, and each one of these scoping reviews have this supplement. So it's a great resource for, if you're trying to do something in the acute care setting that is fast, what tool might you want to use? So in summary, we can do fall prevention work in the emergency department. We really need to build fall prevention skills among ED staff. So one of the things I talk to residents the most is just ask them about their medications. So doing more medication review, thinking more critically about, ambulation trials and other questions you can ask to get a better sense of if that patient is safe to go home. And then there's so many opportunities to collaborate with our team for those people in the room that are interested in falls or digital health or integrating multidisciplinary teams into geriatric emergency care. I'd love to be your point person and work with you on that. Dr. Lum and I have collaborated. It's been really helpful to hear what all of you are already doing in your fields. And thank you.
Well, we'll start with questions in the room. We're working on, and you did wonderfully. Thank you for all of this input, but also making sure to allow great time for discussion. So would love to take questions or comments. Wendy and then Samantha.
Nice job, Liz. Thank you. I don't know if there are any PTs in the room other than Jen, and she's heard this from me before, but you worry that PTs often set the bar way too low for effective rehab to get somebody into a functional state where they might really prevent it.
Yeah, we at Rhode Island Hospital, you really struggled because the PTs that were working with us in the ED were coming off the floors. And the emergency department is a very unique place where people are very frail, but still continue to live independently. And yes, we see them a lot. They cycle through emergency department a lot, but they prefer to stay at home. So there's a lot of struggle, I think, initially talking about, like, we don't want to achieve with GAPcare that we just put a lot of people in SNF. Like really the objective is to send them home and keep them home safely. And so we, fortunately, we had a geriatric PT champion that was well known within that group, and she did a lot of work talking about how, okay to go home and do home PT or outpatient PT. Not everyone has to go to a rehab facility if that's really not in line with their goals. But yes, I worry about that a lot, Wendy, and if you have solutions, let me know.
Gradually populating the world to do more intensive rehabilitation. You don't want them. They're going to get really spending a lot of time on days, and the dosing is just embarrassingly low. So, what all the sweet ball exercises. Yeah, that's an example. You know, my dad had a 100-day stay, and I visited him near the end of his stay, and came in during one of his rehab sessions, and he was doing leg extensions with a 1-pound ankle weight. I said, "Why are you doing that?" They help them get up faster, better. I said, "Well, how much do you weigh?"
Scary.
Yeah.
Part of my postdoc was rotating through SNFs and assisted livings, and I didn't do that until my emergency medicine residency was way over. And I was like, this should be done on day 1 of EM residency, just so you understand that setting and their limitations. Yeah.
I'm wondering if you could speak more to the fear of falling. I was a psychologist in our geriatric care clinic fairly often. At least what I have seen from the literature, which again is somewhat limited, I think, most of the interventions that have been effective have been like exposure-based therapies or trying to desensitize somebody. So, but those take time, and it takes a fairly sophisticated hierarchical approach to do that. And so I'm just wondering if you have any thoughts about fear falling and prevention of that, and intervention of that, or what you've seen when working.
Yeah, I agree. I mean, it was very, when I went to the house of this patient that I was talking about, and we did the qualitative interview, and she's like, well, how do I address that? I felt very much like I didn't have the tools in my toolbox to suggest to her, like, you know, do you do cognitive behavioral therapy, like in addition to all the things you're doing for falls? And the reality is we haven't even analyzed our fear of falling outcomes to see if this trial makes a difference. Actually, Alex Garbin, one of the PT postdocs, is looking at that data right now, but I don't have good solutions, but it's widespread. And I think it's an important component of this that maybe doesn't start in the ED, but maybe starts like in follow-up. But I would love to look into that more.
It's almost like I need collaboration, like somebody that's a physical therapist to be able to truly do like exposure-based intervention that is safe. It takes kind of that collaboration. So I'm just curious. I'm seeing it a lot, and I've done some basic things in clinic where I'll have patients walking with their walker, and we'll talk about, you know, what they're experiencing in the moment, how to use certain skills to try to reduce the anxiety that they're experiencing. So again, like exposure-based interventions, but as a psychologist, part of my challenge is that I want somebody that has expertise in physical therapy to ensure that what we're doing is safe. But so I'm very interested if you continue to look into that with fun.
Definitely. I think it's also a limitation to doing some of these like mobile and telehealth type interventions in the home, because if they really have fear of falling, it's going to be very hard to like mobilize them and move them. And not everyone has a caregiver. And it's yeah, something we really need to look into more.
But on the flip side, if they're so scared that they don't walk anymore, it tends to just get worse. And then they end up doing more. I mean, it becomes a cycle.
Agree.
Kenny?
Great talk. Thank you so much for sharing all this really cool work you did. Also, I'll just shout out at the consent that you managed to do all of this on a GEMSTAR award, CT, and all those other fun things during that. I was curious to know when the PTs did this AMPAC or made this recommendation to go to SNF, how was that SNF state paid for? Like, how did that get from?
If you can repeat the question.
Yeah, so if a PT recommended SNF, like how did that get paid for? The study didn't pay for it. So it was, I'll say that they actually recommended SNF to many more patients and ultimately went. And typically that's because after PT saw the patient, they would get case management involved, and case management would lay out how much that would cost potentially the patient. And we did make clear that like SNF costs are not like provided under the grant. So there were many more people that I think would have liked more intense PT and just couldn't afford it. Mhm.
I think one of the issues we have is, this care setting, I get, then go out and have aggressive PT. What we're faced with is the patient really safe to go home, they don't have enough resources to shore them up, to manage everything, including the physical therapy. Often our patients can't get to outpatient PT, which we feel is best. And home PT, I'm sorry, sucks worse than STAR PT. And then, in between PT session, they're like stuck in a chair.
Yes.
And it's like almost like they go backwards. So we have to go into, what do we do? What's the best thing for the patient? Are we going to make them regress if we send them to the facility, or we send them home? They don't have enough resources, so they're going to fall. So I don't know, how you address that in, these situations in the ED.
Yeah, I mean, I think the pharmacists working together with PTs was actually really helpful. Sometimes we would go to patients' homes and do these qualitative interviews or the home visits, and the caregivers, like the daughters, would be like, wow, since we changed that, antidepressant from the morning to the evening, they're like much more active and willing to like get up and do things. And so I think, optimizing those medications so they're less sedated during the day was like pretty key. But people complained about home PT also. They're like, we never know when the PT is going to show up. And then we're like in house arrest. So instead of like going out and walking and getting exercise, we're stuck at home waiting on this person. So I don't have solutions. And one of the critiques, I think, of this intervention, and there's many, but one of them is like, we really focus on what's happening in the emergency department, and kind of that's a setting we can control. And we would make recommendations, but it was very much up to patient and caregiver to have uptake of that. And we really didn't do booster sessions other than calling them and asking them surveys. And I think that's a piece that, Hillary and I have talked a lot about optimizing. Maybe that's part of it. Like, how do we make home PT better? What's the best version of home PT? That's an answer we haven't, or that's a question we haven't answered, but it's definitely on our radar.
Really move the dial, right? It is more care that's delivered like through watches or sensors or something that's like alcohol, right? But your question is one, she's you're basically making a choice between bars at home, but more independent moving around home, maintaining mobility, versus you're behind the chair and you can't get out of the facility. And the facility is good for staff, right? Have the resources, right? No one, then you're going to be safe, right? From a all standpoint, prison falling so much lower because work hasn't been. So really good to fall very much less muscle atrophy. You're safe. You're having to incur like a really major additional involvement. And how would sit out there. Only if we get our patients to do always exercise and just prior to the therapist, and then there's where you come in. Motivation, all of that.
Mm-hmm.
And they're doing rigorous, not that kind of thing for folks that you get are following. Even though there's tons of benefits. Like I think I would love to invest in programs. Maybe with Alexa or someone. They started creating. And it only got. I was literally went from like helping people try to develop exercise programs to the gym and so to like, can you walk around the house? Like that's the level that's falling to the back. So many more consequences for that, like so much more follow-up.
One of the things we heard about this from this Apple Watch field test is that people really like that every hour they were told to stand. And they actually said that, you know, once they were standing, they were like, oh, I can move around now and I'll go over here and do this and do that. And people actually like some of those inbuilt features, like reminders to just prompt them to go and do those things.
Yeah, I wonder if you could share some of your
Yeah.
preliminary experience of
Mhm.
uptake, usability, acceptability of a device in this population. Is it working?
Yeah.
Would you do it again?
What we noticed in the field test, and we stopped early because I would say about half of the people could not wear the devices each day and charge them. And we had built in a feature where we know if they're wearing the watch or not wearing the watch, and we would call them if they weren't wearing the watch. But often people like didn't understand like how to unlock the phone to get the watch open, and they were like very like basic things that you know, were challenging to do. I think I would still want to use wearables just because there's so many potential benefits, even with the short battery time, but you'd want to pre-screen the patients that can actually do it, because the people that used it were actually very good at using it and answering surveys on the phone and doing these gait and balance tests at home on their own. But then there's this whole cohort, mainly of people with dementia or that lived alone that didn't have a younger person living with them, that it was just too much to overcome. And we would even go to their home and teach them how to do it. And then 2 days later, we got a call like, no one ever showed me how to do this. And so we had one gentleman who's like repeatedly called us like every other day. So it's not a small thing to do tech support for an Apple Watch study in the older adults, I will say. Yes.
Can you just clarify, you provide both the phone and the watch?
Yes.
And the phone is also, it has a SIM card in it, so you're actually giving them not just a phone, but telecommunications and a watch.
Yes. Yeah. And so another issue with that, for instance, is there's scammers that call. So we were like very concerned about them like getting exploited by getting like prank calls over the phones. We had to like work with a phone company, and it was a big ask for a small ward to do this. Yeah.
But looking at wearable devices, and GAPcare has a new product coming out, medical grade. They actually have a webinar coming up November 3rd. I encourage you to attend it. But if you get mobility involved with this device,
Nice.
and it's for research only. It's accurate for physical activities, called the GAPcare. It's a watch, and it has a 30-day battery life.
I love that. Yes.
Having the charge. And so, you know, it's FDA approved physical activity and sleep, which may kind of, you know, build into these measures of fall risk. But it's not, I guess, approved. The studies aren't there yet for the fall or mobility risks. But maybe that's something you could partner with, because we're looking for partners, and I'm happy to share a contract with. They're like $700 a device, and you can get the data sent to a cloud base, and you can do a lot of different metrics with it. You can also get heart rate variability and different things like that. So you can get a lot of different data and movies. But it may be one way you won't get the scammers on the phone because, you know, it's a watch. And you have a longer battery life with this.
That is so important. And I will also say, compared to my other institution, University of Colorado is very set up for these kind of technology studies. And I found it much easier to get things done here. So you're ideally suited to use these devices here if you want to integrate them in your research.
Wonderful. Maybe you get to talk afterwards, but thank you. It's been a great discussion.
Thank you so much for having me.